Today's webinar is part of our COVID-19 action trainings that we've been doing. So with the pandemic upon us, the faculty of Columbia University School of Social Work have been mobilizing with the mission of monitoring developments and disseminating information that can be helpful to social workers, our multidisciplinary colleagues, and the clients that we serve. So today's webinar is specifically on family caregiving policies, programs, and services, caring for older persons and the caregivers. And we are thrilled to have our presenters, Dr. Jeanette Takamura. She's a professor and our Dean Emerita of the Columbia School of Social Work. Richard Hara, one of our lecturers, and Jinyu Liu, one of our associate professors. And so with that, I decided to turn the mics over to you guys.
So thank you all for joining us on this afternoon in New York and different times around the world. I'm at about 7 o'clock in the morning in Hawaii, so I'm still getting up, but it's a pleasure to be here. And it's also wonderful to see so many of your names. Hi, Bonnie, and hi, everyone else. So as we go ahead and note what we are aiming to cover in this webinar on family caregivers of older persons within the context of COVID-19, we're going to just pause for just a few moments, and I'd like to ask you to respond to a poll that you'll see in just a few moments to tell us a little about you and your interests. So here's the poll. Tiffany, someone said that they can't see the poll.
All right, so the poll automatically does appear for everyone. However, if someone is Zoom application is not updated, then they may very well not see the poll. So it was also helpful to probably to go ahead and just read what the poll is asking. And so for anyone who may not be able to see the poll, then you can just like type your response into the chat box. So the poll is asking, are you a student, a community professional, a higher education educator, staff, or administrator, or researcher, a CSSW alumni, or other. And for any of you guys who have selected other, you can also feel free, please, in the chat box, let us know who you are in regards to the other category. And then Jeanette, I'm going to go ahead and in the poll and show the results for this one.
Sure, that would be great. All right. So what we can see is a lot of you are community professionals or CSSW alumni. So welcome home, folks who are alums, and welcome in general to everyone else. It's a pleasure to have you join us this afternoon. And is there another question that was going to come up?
All right.
And then I saw someone from London and someone from Israel, but the bulk of you, I think, are from New York and probably even New York City. But do let us know where you're from.
So the question for this poll is, where are you from? New York, another state, or outside the US? All right, so I'm gonna go ahead and end this poll and show the results.
All right. Okay, so the vast majority of you are from New York, and so we will have a very large number of things that are shared experiences. For those of you from other states, you've probably read about what's going on or watched television and seen our Governor Cuomo in his daily broadcasts, and I hope that you also have found him to be very informative. From those outside of the United States, hopefully you'll get a better picture of what's happening with elder caregiving within the US and particularly within New York from this presentation. Thank you so much for responding, and thank you so much for joining us. So let's go to the next slide. These are the aims of the webinar. I'll give you like just a few nanoseconds to take a look at it, and then we'll move on to the next slide. So this image conveys a whole lot about family caregivers of older persons who are living in the community, but give it some critical thought, will you? And we're going to bring this slide back a number of times. The question is, who in the United States is caring for whom? Now, since February, a pandemic of just epidemic proportions, pandemic proportions actually, has hit us, beginning from Asia, moving to Europe, and then of course to the United States, and certainly to New York. Meanwhile, we've experienced some horrific murders of our African-American women and men in particular across the country. And this is just, these episodes have been just fully shaking. And I'm just hoping that this is the transformative moment during which we can really make that statement and bring to life the fact that Black Lives Matter. There is one good piece of good news, and that is that the US Supreme Court, almost unbelievably by a 6-3 vote, decided to support transgender persons in the workplace. But let me go back to COVID, let me go back to caregiving and say this. Some experts have said that the COVID-19 pandemic is much worse than any they had been anticipating and making plans to counter. Next slide. We were stunned when we watched on television and saw in the news these pictures of people who were in fact dying or being hospitalized. And I think you saw them as well. This was not just in New York State, it was all across the country. Next slide. Of course, in New York City, in New York State and the tri-state area, the incidence of COVID and the deaths that can be linked to COVID were just astounding. And I think this is what put lots of us on alert all across the country. So very serious, matter of concern for all of us. Next slide. And certainly, if you look across the country, look at the total population of the US, the incidence of COVID as of about the middle of this month, and then the number of deaths in this country, 80% of them occurred with within the older adult population. So I want to say one thing about this, and that is there was a comment made recently that if you consider the probability of persons 75 years of age and older dying from the coronavirus, it is 10,000 times greater than for infected 15-year-olds. That just took my breath away. Next slide. This table displays the incidence of COVID a month ago in New York City by age cohort. And it drills home once again how the older you are, the more vulnerable you are. Next slide. We all know, this is not a secret, that death rates among men have been much higher than among women. Next slide. From March to April and to now, we have seen a significant and deadly impact upon communities of color. It's not a surprise, given everything that we know about health disparities by race and poverty. Okay, so we go back to the slide. Okay, thank you. We'll go back to the slide that is a Rorschach as far as I'm concerned. It should raise some thoughts and questions. Did you wonder about who the actual caregivers are in this photo? I couldn't decide whether they are the two people in the middle, and I wondered whether the little girl was actually somewhat involved in caregiving as well. It's not necessarily the case that that isn't happening in the US and in other places around the world. Also, I couldn't help but wonder, is this a multi-generational family of probably middle-class women? And what about low-income women, women of color, and single women who have always been the caregivers most at risk, COVID or not? And let me just say this, that last month, a new study was released that was built off a survey of about 3,100 women. And it said that for women who are 18 years of age and older, more and more of them within this COVID environment are actually working double shifts. In other words, they're working in the workplace if they still have a job, then they'll go home or, while they're at work, be very concerned about their child. And when they go home, they'll not only take care of their child, but also their household. But add to that, now in the COVID environment, more and more women are also caring for older adult family members. So this has been called the double shift. And I will say that this double shift is not news to poor women or women of color. I draw from my own experience, and I remember when my mother and her three sisters all took care of my grandmother. Now, here's the difference. There were 4 women caring for their mother. In today's environment, our families are much smaller, and so you are not apt to see as many people caring for an older adult. So studies of caregivers, for the most part, have focused mostly on caregiving needs, but there are needs that exceed just the domain of caregiving and go, when we talk about and think about caregivers, to their economic, health, and mental health insecurities. And so we're going to talk a little bit about that as we move through this particular presentation. Now let me pass the baton to Jin Yu.
Thank you, Jeanette. So before talking about the effects of pandemic on caregivers, let's look at some statistics and facts about the older population and their caregivers in the United States. Now there are about 55 million Americans who age 65 and older, accounting for almost 17% of the US population. Among these older adults, only 5% live in nursing homes, and the majority are dwelling in communities. However, 1 in 5 older adults in communities rated their health as fair or poor, indicating that possible needs of care. And the 7% of these older adults actually need very intensive care, such as help with personal care. Here are some statistics about family caregivers. There are 40 million Americans taking care of their older family members in communities. Among these family caregivers, 21% aged 45 to 54, and 24% age 55 to 64, which means these caregivers are about to enter their later life. And 18% are actually older adults. These numbers tell us that majority of family caregivers are middle-aged or older adults who already have started coping with issues related to their own physical, mental, and social aging process. Half of the family caregivers provide care for no more than 2 years, but 15% actually keep their family caregiving responsibilities for older relatives for more than 10 years. In most cases of the long duration of care, care recipients may have cognitive impairments, or we call it dementia. What do family caregivers do? Assistance with activities of daily living, which is also called as ADL care, is the most common type of care tasks that most family caregivers need to do, because their care receivers have challenges in mobility, eating, transferring, toileting, continence management, and bathing. Help with instrumental activities of daily living is another important type of family care for older adults, such as financial management, cleaning, cooking, health management, providing transportation, and listening or answering phone calls. As I will present in the next couple slides, COVID-19 causes challenges for all types of caregivers, including informal caregivers who live or do not live with the older family members, and formal caregivers who provide care for older adults for living. At the same time, the quality of life among all the care receivers, regardless from what sources of care they receive, are also influenced by the pandemic. The pandemic could cause several challenges in ADL and IADL care. For example, the preventive practice is very challenging when care receivers and caregivers are infected or have risk of infection. As we can imagine, it is almost impossible to keep a social distance when providing or receiving personal care. The preventive power of facial masks may be also dampened without a social distance. And sometimes wearing a mask could be inapplicable under certain contexts, such as care for eating or bathing. For dementia caregivers, they may also have to deal with the care receiver's uncooperative behaviors, such as the rejection of wearing masks. During the earlier period of pandemic, getting groceries was not easy, as we all, especially New Yorkers, could remember. For caregivers, they have concerns of getting the virus while going to the grocery stores. And more importantly, they are concerned about transferring the virus to their care receivers who are more vulnerable. In many families, there are primary and secondary caregivers. When one caregiver goes to the groceries or run errands outside, the other caregiver could stay with the care receiver at home. But in the pandemic, many secondary caregivers could not offer such help because of concerns on safety in public transportation or necessity of quarantine. For many dementia caregivers, it's almost impossible to leave their care receivers alone at home, even for just a little while. Chronic condition management is pretty challenging, primarily because of the safety concerns in the trips to the doctor's office and the pharmacies, and the risks of getting the virus in the healthcare settings. Some caregivers provide care for their older family members living in nursing homes. For example, I've heard a caregiver whose husband have to live in the nursing healthcare center due to the daily needs of professional nursing techniques. Though her husband was receiving institutional care in the past few years, the caregiver visited him every day and provided all the personal and emotional support or care for her husband. However, when the pandemic started, the healthcare center prohibited family visit to minimize the virus transmission. Sadly, without the care and the company from his wife, the husband passed away in May. Hospitalization. Hospitalization of care recipients and the caregivers becomes more challenging no matter whether it is caused by the COVID-19 or not. As we all know, the risk of getting hospitalized because of COVID-19 is pretty high among older people. So both care recipients and their caregivers are riskier to be hospitalized if they got the virus. During the pandemic, many hospitals do not allow family visits or accompany with the patients. Of course, this is very reasonable, but for some older patients, especially those with dementia, it could be very challenging if the caregivers don't stay with them in the hospital, where the environment, the treatment, the care in the hospital may cause confusions for these patients. Sometimes the needs of hospitalization are not caused by COVID-19, but under the pandemic, it is very hard to decide whether to go to or stay in the hospital. There are also some concerns related to home care services. As I mentioned, some older adults receive care from formal caregivers, usually coordinated by some agencies providing home care services. Both care receivers and the formal caregivers have concerns about the risk of infection. Many agencies did not prepare well to deal with the pandemic without sufficient protective equipment. Many formal caregivers actually had less enthusiasm to keep providing personal care for their clients. In addition, many formal caregivers could not work because of caregiving responsibilities in their own families, such as taking care of the little children who could not go to school or daycare. So without the home care services, many family caregivers could not have any respite, which could cause huge physical and emotional exhaustion, especially for dementia caregivers whose care tasks are usually demanding and intensive. Besides the challenges of ADL and IADL care and the healthcare management caused by COVID-19 that I mentioned earlier, dementia caregivers also have to deal with behavioral symptoms of their care recipients. So one particular challenge or issue for these caregivers is to rebuild the routines for their care recipients with dementia, because COVID-19 has broken their daily routines to some extent. For example, some outdoor or social activities have been limited. Then how to fill the schedule that were used to be occupied by the outdoor activities is a new theme for many dementia caregivers. So if a new routine with new meaningful activities is not created, people with dementia will have more mood disorder, such as frustration, anxiety, or even depression. Caregivers may also feel burnout when handling the behavior problems. More importantly, the care recipients may have a faster cognitive decline. That's the very serious consequence. So it is harder to adapt to a new daily routine for people with dementia. Also, designing of a new routine with meaningful activities must be individualized based on the care recipient's interests and the capacities. So working with my students, I've designed a guideline offering creating indoor activities for older adults with dementia. So both English and Chinese version could be downloaded from the Columbia China Center. Another group of caregivers are the ones who have caring responsibilities for multiple family members. In many multi-generational families, the middle-aged women are very likely to provide care for their older parents and the little children at the same time. They have to balance the needs of the older and the younger generation. So we call them as sandwich generation. So in the context of COVID-19, the caregivers in multi-generational families have more caregiving work because little kids stay at home, and some caregivers may experience more economic stress due to the effects of pandemic on their employments or their household income. Also, family relationships could be very challenging when multiple generations live under the same roof during the quarantine. As the longevity keeps increasing, another small but growing group of caregivers are those providing care for family members across even 4 generations: their older parents, spouse, children, or even grandchildren. So most times these caregivers are older women. existing studies have shown very, very limited knowledge about these caregivers. So we know that caregiving could bring both rewards and stress to these caregivers. And we can also imagine that COVID-19 may create some new stressors for the caregivers in the 4th-generation households or families, such as more work to supervise the grandchildren, challenges in health management for the older parents, their spouse, or just for themselves, economic stress of the children, again, complicated multiple generational relationships. The above discussions on family caregiving under the pandemic are primarily based on the stories that I've heard from family member caregivers or the community service providers who I work with. Many systematic review, more systematic research is needed to identify their stressors and find possible solutions to support these family caregivers. In the next part, Jeanette will discuss what supportive policies we have so far and what we could do more.
Thank you, Jinyu. Next slide. Okay. So I will be spending the next few minutes talking about policies and programs. And one of my sheroes of all time for now about 4 decades is Julia Tavares Alvarez. And she is really someone who has been able to capture a lot of what we need to do and think in the field of aging. So this is a quote that I'd like to share with you. She actually said this maybe about 4 decades ago, but her observations back then still are very relevant today. Essentially what she was saying is that, unfortunately, government tends, this is the gist of it, government tends to respond to near-term needs, but they don't seem to be able to also be planful and be able to put into place things for the long term. So she noted, we do not have essentially the social policy equivalent of bifocals. So I love Julia Tavares Alvarez. Words of wisdom from her I just wanted to share. Next slide. There have been real challenges to income security for all Americans. There's no question about that. What is startling, though, is the unemployment rate among people aged 65 and older. And between March and April, that rate quadrupled from 3.7% to 15.6%. This is more than the 14.7% lost by persons 16 years of age. Now, for many, the loss of a job really means more than just the loss of an income or the loss of a routine or the loss of one's identity. Without being employed, it's entirely possible that their health security plunges, the retirement income security is placed at risk, and everyone's needs, everyday needs, including those for good quality food, etc., are not met. So the Kaiser Family Foundation has found that low-income women, and particularly women of color, are placed at greatest risk by COVID-19. Now, before we go to the next slide, I just want to insert a little editorial here. It's very, very difficult every time to note where those disparities are and to continue to see that our policy creep is so slow that we're not able to respond adequately to those populations at greatest need. Next slide. Okay. So as I was saying, you know, the impact upon women of color and women who are poor tends to be much more significant than other segments of the female population or the entire population in general. And we know from, again, a study that was just released this month, I believe, that there are more hours spent by Black and Latino women on childcare and also in giving care to older persons. Next slide. So there are some policy interventions, some of them are temporary, that were meant to actually assist people who are in the workplace or have just lost jobs. And I'm going to note two of them that came out of the Families First Corona Response Act that really is not just for caregivers, they're for everyone. But caregivers are people, and when they lose jobs, they also need to take care of themselves. And so the first temporary rule actually that was issued by the Department of Labor expires in December 31st of this year. And that permits employers to provide emergency paid sick leave to their employees. But there are conditions that must be met, and those conditions are noted there for you. The employee is quarantined, or the doctor advises quarantine, or if they have COVID symptoms and they're waiting to be diagnosed, or if they're caring for a child without care because they can no longer go to childcare or to school because of COVID, then there is a possibility of taking emergency paid and sick leave. Now, the other provision, again under the Families First Corona Response Act, enacted on April 1st of this year, again is a temporary rule. It again expires at the end of this calendar year, but it does provide people with access to Emergency Family and Medical Leave Act. And they can be paid, but the amount of payment they may receive could be 2/3 of their actual take-home pay usually, or their full check. And what I think is important to note with respect to this particular concern is that 2/3 of minimum wage workers are women. And of the people who are low wage, 70% of low wage females and many other women and male workers didn't have a single day of paid sick leave that they could count on when COVID erupted. Not a single day, 70%. All right, so fine details that accompany these two provisions. So I would send you to the Department of Labor website to get the very specific information. There are lots of conditions. I've just provided you with a few, but important to know that this is temporary and it also expires at the end of the calendar year. It says to us, though, based on a study that came out of California, because California has a mandatory mandatory Family and Medical Leave Act, that if we were to provide these kinds of benefits on an ongoing basis, then we would likely see fewer people in nursing homes, more people being cared for in the home. As a consequence of that, California state is saving some money. Now that sounds great if you're looking at the state budget, but let me editorialize a little here. If people are staying at home, they're being cared for in the community, it's usually the case that family caregivers are providing the care. And so what happens then is we are once again placing the burden upon women who once again will be sharing a double shift. So while we may celebrate how California is saving state dollars because not as many people are going into nursing homes, the less visible impact is what happens to women who then are compelled to move into caregiver roles. Next slide. Okay. So there are challenges to the health security of caregivers. And here, once again, I have to note that it's communities of color, and in particular, women of color, who are experiencing significantly worse COVID health outcomes. Now, if they're laid off, then as I mentioned a few minutes ago, their employment-linked health benefits are lost, if they have them. If caregivers are poor and unemployed, they're likely on Medicaid, which then depends upon what their state's willingness has been to expand and fund coverage. So there are a few options that can be pursued, but every one of these has lots of details that go with them, and I'm going to give you a very quick, broad stroke look at these. Next slide. So the Affordable Care Act offers a special enrollment period for people who are not on ACA. However, whether you can get in depends on the state's insurance marketplace. And the other thing that I do want to note for you is that there can be help with premium subsidies. However, I would again check with the Kaiser Family Foundation, and the link is provided there for you, to see what those subsidies might be, because again, it's very complicated and there are lots of variables that go into determining what the premium subsidies someone may be able to get might be. Now, I want to point out something that I think we should keep our eyes on, and that is the finalized rule for Section 1557 was issued not too long ago. And that particular rule tries to eliminate the protections and limit redress against discrimination, particularly for the LGBTQ individuals and for persons who have limited English proficiency. So very important for us to keep an eye on that. It means that even with community input, the rule went through. The other policy provision that has been longstanding is COBRA. And I think we all know about COBRA. If you're in an employer-sponsored group health plan and you lose your job, you usually can continue in the group, but it's only for 18 months. And it can be very costly because for the most part, if you sign up with COBRA, you're covering the cost out of pocket, which can mean about 102% of the cost of the plan. I want to go to Medicare. Medicare has now offered telehealth by phone and video. Well, that sounds great, but what if you're poor? What if you don't have a computer? What if you don't subscribe to internet services? Doesn't help. And those are the populations most at risk. If you did not enroll when you were first eligible, usually at age 65, then you have 8 months to enroll, when you become unemployed. So it's important to remember that. Now, some limitations with respect to Medicare are only now being experienced. Under Medicare now, doctors are experiencing about a 10% cut in reimbursement. And they also have pay for quality requirements. So what I'm hearing from the MD community itself is that many MDs are not happy with the pay for quality requirement because it places more onus on them to do more paperwork and to meet more requirements. And so there are more MDs who are opting out of being Medicare providers. In New York City alone, if you call and want to get to a doctor of your choice and they ask you, what kind of insurance coverage do you have? You will find that fewer and fewer of them are willing to take on Medicare-insured new patients. And what I have found in calling around to doctors in New York City and other places, that more and more doctors are even opting out of taking patients who have any health insurance whatsoever. They are opting instead to take only private pay individuals who are able to pay out of pocket for their care. So this leaves us with federally qualified health centers, which I talked about in my policy class this last semester. Most people don't pay a lot of attention to these, and it's not given a lot of publicity. And what I will tell you is that I've always felt that their funding levels are totally inadequate. And additionally, they really are not located everywhere. So federally qualified health centers were set up to serve underserved communities. They are for low-income, uninsured individuals who have limited access. So it can be the homeless, it can be those who are, immigrants without papers, etc. But it's really tough because their funding levels are very constricted. Next slide. If we want to look specifically at caregiver support policies, then there are a few. The major one, I would say, is the National Family Caregiver Support Program. And there are several titles in the Older Americans Act, and I'll be speaking specifically about the National Family Caregiver Support Program for about a minute or two. But there are several titles in the Older Americans Act that actually support caregivers. So when my team and I were putting together this support program, it was never the intention for this to be the caregiver support program to carry us into the future forever. In fact, frankly, what I would like to see, this is my personal dream, I'd like to see a comprehensive, universal, long-term care policy by the federal government that will cover everyone, irrespective of where you live and irrespective of the kinds of long-term care services available within your community. Because the provision of that kind of program would then have a multiplier effect. It would mean that more services would come online. It would mean that people would have more choices, etc. And part of the reason that I really am passionate about this one is unless we have a national program, we are resorting once again to putting the burden entirely on women and without any kind of support. So there was a CARES Act that was passed that provided supplementation to many federal programs. And here, the amount of money provided for the National Family Caregiver Support Program was a piddling. And let me just say that even with that money being provided, we face the quarantining issues and labor force issues that make it very difficult to get paid caregivers into the homes of individuals living in the community. The other act that provides support for caregivers while providing support to those receiving care would be the Older Americans Act, Title IIIB and Title IIIC. Title IIIB was actually established maybe about 50 years ago, and it really was the spine upon which the notion of home and community-based services began to develop. So with both Title IIIB and Title IIIC services, what is essential is that the state must provide a match, local governments must provide a match, so this is entirely discretionary. It means that states will fund if they have the monies and not fund if they don't, or provide very limited funding. So again, there was some supplementation provided, but again, I would say to you that the supplementation was really a piddling. The largest amount went to the Nutrition Services Program. And for those of you not familiar with Older Americans Act Nutrition Services, that means meals served in congregate settings like adult daycare, senior centers, churches, etc. Or there can be home delivered meals. And once again, we have to remember quarantining and labor force shortages. All right, next slide. Some other policy provisions that can be very supportive to family caregivers. There are some Medicaid features, that support family caregivers. And it all depends on the state. So location is everything when we think about Medicaid waivers and how they impact upon older adults and family caregivers. If a state has a Medicaid waiver for consumer direction, that means that the person who has functional limitations can actually provide reimbursement to a family member providing care for them. Now, there's another Medicaid waiver that tends to be available in most states, and that's for managed long-term care. Great, because it coordinates long-term care services. The challenge, once again, is that hours are being cut in many states. So the final piece that I want to mention, again, coming out of national policy, is that the Veterans Affairs Department is in the process of putting online services provided in partnership with LinkedIn. But here again, I'm going to say, it depends on whether you have technology and it depends on whether you have connectivity. So there are also lots of features of this program that they're putting online that are not available to all veterans across the country. So I would say check with the Veterans Affairs Department, see how they're moving along as they mount this particular online service, and also see what you can find out about the program of comprehensive support to family caregivers. Next slide. So we go back to this Rorschach of a photo, and let me pass the baton now to Richard, who will be covering best practices.
All right, thank you, Jeanette, and thank you, Jin Yu. Before I move on to the last part of our panel presentation, I just wanted to note that we do have the chat box open and also an area for Q&A. I haven't seen questions yet, and I hope people are thinking about questions because we have reserved time at the end of this presentation for Q&A. So if you've been thinking about questions, please start writing them into that box. And also, you know, this is a wonderful interactive opportunity, I hope, for all of you in the audience to connect with other people out there doing this work, part of the social work profession. At the beginning, we did the poll, and certainly the majority of you are working professionals in the field. Some of you may actually be in healthcare. And I want to say, first of all, thank you for the work that you're doing at this time of a pandemic. And I know that a number of social workers are also you know, working in agencies where they have direct contact with patients and caregivers as well. And perhaps this final section maybe will be helpful for you in terms of doing this direct practice. So, okay, so we are on to the next slide, looking at core areas of caregiver need. And I know the focus of our presentation today is caregiving in the context of COVID-19. So that necessitates more of a focus on caregiving and the intersection with the healthcare system. So right at the top, I'm looking here at those 2 bullet points that information and support are critical to our caregivers. Caregivers are often sort of put on the sidelines in hospitals and doctors' offices and so on. They're not told as much because there are issues of privacy and so on, but also because, you know, at the same time, they want to get decisions directly from the patient, and caregivers are an afterthought. And that speaks to that second bullet, that caregivers often receive less support than the patient, both from the healthcare team and the family. And in fact, I believe there's recent survey information coming out of the National Alliance for Caregiving and their 2020 Caregiving in the US report that has looked at how few people, caregivers, are actually asked by their healthcare team, you know, what are their needs? In fact, only 13% of respondents said that they were directly asked by the healthcare team, well, what do you need as a caregiver? So it gives you an idea of how they're being sidelined. So the next bullet point, obviously, communication is a core area of caregiver need. Communication with doctors and the healthcare team, but also with their ill partner. And this is you know, part of the family dynamics issue and so on. And certainly we've gotten a good picture of that from Jin Yu in terms of how she's been looking at family structure and household dynamics for caregiving. Finally, another core area of need is how to cope. Looking first at practical problem solving, but also managing emotions and stress from the caregiving experience. So we'll come back to this in just a bit. Next slide, please. So this is to reiterate what Jeanette had said previously about the different levels of service as set up by the federal government. And on the left-hand side, you can see, you know, the Administration on Aging at the national level, state units on aging, SUAs and tribal organizations, moving down area agencies on aging, AAAs, and then finally to local service providers and direct services. And I think apart from, you know, sort of the structure is sort of noting that this allows for what's called the no wrong door approach, all right? That wherever people in need of service might enter into the system, there is a structure that will funnel them down to that level of local service and connecting them to the right-hand side of the slide, which sort of documents the kinds of services that are at the heart of this, I guess, model of caregiver support as designed by the federal government, and certainly as outlined by Jeanette previously in terms of the history of federal services. So you have access to services, nutrition, home and community-based services, disease prevention, and health promotion. Next slide, please. So as we're talking about best practices, the National Family Caregiver Support Program does provide us this sort of template for what are best evidence-based practices to support caregivers. And you know, the first point there under National Family Caregiver Support Program is the objective. It provides grants to states and territories to support informal family caregivers and home and community-based elders for as long as possible. Okay, so with that as an overarching goal, what kinds of services are most helpful to caregivers? Well, you've got information about available services, you've got assistance in gaining access to the services, individual counseling, organization of support groups and caregiver training, respite care, and supplemental services on a limited basis. And I think it's interesting that you have respite care there, you know, sort of acknowledging that, you know, the needs of caregivers are such that, you know, maybe more than support, you need to sort of just give them relief, right, from all of that caregiving work that they're doing in addition to everything else in their lives. All right, next slide, please. So talking about respite from what? Jeanette talked about this double burden, right, that caregivers have or are experiencing, that caregivers need to care for at least two people, all right, their loved ones and also for themselves. Women spend 50% more time as caregivers to older persons, again, to sort of look at this in terms of special populations and particularly for women. The bottom part of the slide outlines for you the basic family caregiving tasks, physical and medical care management, financial issues, and also psychological coping, anxiety, depression, burnout, not just on the part of the person or the recipient of care, but also the caregiver and their own needs. So next slide, please. So I'm drawing here upon my own work. In medical social work, I've worked in hospitals, I've worked in the community for a nonprofit organization, serving people affected by cancer. And I just wanted to just share the things that you would hear from caregivers of individuals experiencing life-threatening illness, right? What do I say to my ill partner? I don't want to cause more suffering and pain. Whom do I tell? How much should I disclose to others? I feel like things are out of control. I don't want to complain. I'm not comfortable asking for help. And counseling is not for me. I don't know, for those of you who are working in the field or have worked with caregivers, which one of these resonates most with you. For me right now, I kind of think that the middle bullet point about I feel like things are out of control speaks for a lot of people who are in a situation where this is all new. You know, getting healthcare, managing and navigating the healthcare system is like entering into a different country with a whole new set of rules and culture and everything else. So there's that aspect of trying to get people, right, the information, as we were talking about before, that would allow them to work their way through the system. So let's see if I can move on to the next slide, please. Okay. So, not sure, there was a slide, and maybe, Jin, can you check if we can go back? Oh, caregiving and its impact on mental health. All right. So caregiving has obviously a tremendous effect on people who are giving care. But I want to acknowledge that caregiving has both positive and negative effects on the quality of life for both patients and caregivers. And talking about the positive effects, for people who are giving care, they feel like they're making an important contribution, not only to their loved one, but also to their family. They might experience increased closeness with the care recipient and improving relations. Giving care also can lessen worry on the part of the caregivers and others, knowing that there are things that they can do and that they can help to, help to support their loved ones. And finally, as a result of caregiving, people often develop new skills, new capabilities that they might not have had, right? As a result of their experience navigating the healthcare system, advocating for their loved ones' well-being, and so on. That said, I think we do have to note that a lot of the research and discourse on caregiving tends to focus on the negative effects. And I haven't included a bullet point here, but first and foremost, and I think Jin, you referred to this earlier, there is a significant effect or impact of caregiving on the physical health of caregivers. In fact, there's a study, or there have been studies that show that beyond caregivers reporting poorer health, right, as a result of caregiving, that some researchers see a link from caregiving or between caregiving and also increased mortality, particularly among elders. So that's just one basic thing to keep in mind, but also the mental health effects, that 40% of caregivers experience depression. And I've seen different figures, and it may be, and they range from 40 to 70% of caregivers so demonstrating symptoms of depression. Doesn't mean they meet criteria, DSM criteria for major depression. But then again, there are some studies who say that caregivers from 25% to 50% of caregivers might actually meet criteria. Now, I know there are controversies about, well, are we now pathologizing caregiving and turning it into a sort of DSM diagnosis the same way that we, have had issues about bereavement? And I just think that, the basic issue is that people are distressed and they need help no matter what sort of label we want to put on it. Okay, so, and you can look at reports like the Families Caring for an Aging America, which was published in 2016 by the National Academy of Medicine, for more information about the physical and mental health impacts of caregiving. Okay, next slide. So I talked about that. Actually, let me just, to go back to that, I think, sort of some of the themes that come out of these statements relate to, as we've said before, communication, ventilating feelings and concerns of caregivers as important goals of practice that we do with caregivers. We need to problem solve and help caregivers take positive action so that they can regain a sense of control and efficacy, since I feel like things are out of control. And then finally, I'm not comfortable asking for help. Counseling is not for me. I think working with caregivers to help them understand and know when they need to ask for help. Informal help, family help, certainly, but also professional help. Okay, we can move on to the next slide. Thank you. So these are just kind of tidbits, things that might open up a bigger conversation about doing social work practice with caregivers, and certainly within the context of COVID-19 and other life-threatening illnesses. But I sort of had put them together here to start that conversation. So we've talked about people's stories. You brought them up with regard to her research. And I think in clinical practice, we always make space for people to give voice to their suffering, but also to help make connections, right, to care, right, and the people that can support them. Pre-existing struggles with mental health can be exacerbated by healthcare encounters. We've seen that the healthcare experience itself, going into a hospital, being in an ICU, can actually be a cause of trauma for people, and also activate previous coping with trauma in people's lives. So it's something that we need to be mindful of, and also that, yeah, it can trigger anxiety and depression. Respect people's way of coping, and that even denial can be necessary, right? I think that this is particularly pertinent when you're working with people in an emergency situation like COVID-19, where needs are particularly acute, and maybe there isn't a great deal of information, and you don't have the time to sort of work your way through every single issue. And for people who are coping with COVID-19 as a patient or caregiving, you have to reinforce what they already know, right, on how to cope, right? To shore up their strengths, their capabilities, and so on. And even denial might be one way for people to just get through that. And as much as we say, or we want people to be informed consumers and to be making decisions based on all of the evidence available, and to have self-determination in doing so, that has to be tempered with the emergent nature of the situation and working with within the healthcare setting. With regard to communication, ideally it's open and honest, but as I always say, it doesn't have to be brutal, right? People need facts and so on, but maybe they don't need them all at once, or maybe they have to be phrased in a way that, and this is sort of jumping down to the bottom bullet, but in a way that always allows hope. All right, we want people to sort of understand, what's at stake and so on, but at the same time, to give them that opportunity to hope and to be optimistic about outcomes. And finally, personal growth may occur in the context of a life-threatening illness, but doesn't have to. And even though I wanted to sort of reserve this last part of the presentation for a more clinical focus, I don't want people to sort of come away with the impression that this is about doing therapy with people who are working through severe medical crisis, and either as patients or as caregivers and so on. And it's wonderful. And if we can shore up, again, people's existing strengths, that is certainly a starting point, and hopefully a foundation for sort of advancing and developing new skills, as we've talked about, as a result of the experience. I know I'm running short on time, so let's move on to the next slide. Okay, so one of the best things that we can do for caregivers is remember or remind them to care for themselves. I know most of you as social workers know what it's like to give care, since you are professional caregivers. And I know that you've probably worked with caregivers and used that analogy that I've used and many people have used about being on that airplane and being told that if there's depressurization and the oxygen masks come down, you have to put on your own mask first before you can help anybody else, right? So caregivers have to attend to their own needs, even though they feel this overwhelming pressure, right, to take care of others. But in order to do that, they need to replenish themselves, nourish themselves physically, psychologically, and spiritually. And we've got the bullet points here. And I know that you've probably worked with your clients to help or provide ways that people can attend to themselves, nutritionally speaking, and so on, to use breathing exercises, journaling, and other things that promote mindful awareness, stress management and relaxation, but also spiritual activities. I think it's important in the face of life-threatening illness to bring people back to what matters. I mean, what is the meaning of this experience for you, in order to create a base for understanding their coping actions. And finally, social support. And this is just so important for older caregivers because social isolation is one of the greatest risk factors for negative mental health outcomes for this population. So something to keep in mind. Moving on to the next slide. All right, so want to just finish up with some information and referral. There are a number of online services for individuals and groups through national nonprofit agencies. I've listed 3 major ones here: National Alliance for Caregiving, Family Caregiver Alliance, and the Caregiver Action Network. And you can certainly Google them and look at all of the services that they offer, which are in main computer-based. And as wonderful as that is in the midst of a pandemic and social distancing, it might not be a fit, this particular medium, with all older caregivers. So there is a wealth of telephone-based support. And again, going back to No Wrong Door, state and local municipalities have warm lines that offer emotional support to people who can call in. And also in local communities, senior centers, they have their friendly visiting programs. And while I don't think they're sending people out right now to visit older people, they are doing telephone calls and so on, and helping people to feel connected. Next slide, please. Additionally, there are sources of support that go beyond caregiving specifically, though the National Elder Care Locator is one place that people can call to get information about caregiving resources, respite, home care agencies and supports and so on, and the Caregivers Corner, which is also another federal government helpline, ADRCs, SAMHSA for mental health support, National Alliance on Mental Health as well, Alzheimer's Association for long-term caregiving, and you can sort of skip down there to the New York City Department for the Aged for more local community resources. Next slide, please. Well, that's it. I'm sorry I took up a little bit more time, and I hope I didn't take away. I do see that we have some comments in chat and maybe some questions and that people have submitted in the Q&A box. So again, I just want to thank everybody for joining us here today for this presentation and conversation. And I guess throw it back to you, Tiffany, to facilitate any comments or questions that we've gotten from audience members at the time that we might respond to.
Yes, definitely. So like I said before, we're going to try to get through as many questions as we can. So we have a few in the Q&A box, but please, folks, go ahead and add to those questions. I do want to start off, Jeanette. I know that there was a couple of questions that caught your eye. So let's lead with the 2 that caught your eye first.
Okay, I think one of the questions had to do with adults who have developmental disabilities and how to get to supports. Mm-hmm. I would actually start with that elder care locator. They can connect you in as well. And to be quite frank with you, they're part of the federal government is the Administration for Community Living that you should probably go through. It's acl.gov, www.acl.gov. That'll give you access to resources for the disabled population. ACL is a larger organization that resulted with the consolidation of aging with disabilities. So go ahead and go through that. I think there was another question related to connectivity and would it be a good idea to perhaps make computers available to elders, et cetera, in community spaces. I think that's something that different organizations will need to think through very carefully. I think it's a good idea. The question comes down to logistics because you need somebody there to attend to the technology, help people log in. You know, it's really a little more than having a computer and having the connectivity. Even for myself, it's been really difficult to participate in telemed without knowing the system that they use. And the docs have told me that they're struggling with it as well. So good idea to have it in the community. The question becomes, what will be the logistical setup to make that available? So very good question.
If I could jump in real quickly with regard to the question about services for people with developmental disabilities, I think for the people who are in New York State, you can go to the OPWDD for state services for people with Office for Persons with Developmental Disability, OPWDD. They should be able to provide a whole host of information with regard to services for adults with developmental disabilities. So I want to just add that in as well.
All right, thank you. And then this question is specifically addressed to Dr. Liu. Can you suggest activities that a resident in a nursing home confined to their room and wheelchair can participate in for enjoyment? And like, how do their caregivers, how can our caregivers help facilitate those?
Sure. Actually, I will send you the link maybe to the chat box so later where you to let people to download the guideline to create indoor activities for people with dementia. But I think some of the principles and the tips probably could be also applicable to the care receivers, you know, as the question mentioned, like who may have mobility issues and probably spend most of the time indoor. I think the key thing is the caregiver should know the history of the patients. I mean, the care receivers, what he or she likes, and like music, painting, puzzles, that's all could be done in, you know, at home, even or indoors, even, you know, the care receivers stay, you know, on wheelchairs. So I think there are more details in the tips or the guideline that I developed. So I will copy the link and paste the link to the chat box that everybody can see it, could download it.
Thank you. And then regarding telehealth and telemedicine, is there guidance or best practices on how many televisits should occur before an inpatient or at-home visit should occur?
So actually, this depends a lot on the individual doctors. Some, for example, the doctor that I know very well, one of them that I know really well, says that at this point in her practice, she's only seeing 1 to 3 patients in person, and they're moving all of their other patients pretty much online. So it really depends. You've got to check with your physician.
And then with this also too, has elder abuse been on a rise with COVID? What have you guys been seeing reports of?
I think, well, I can't speak about elder abuse specifically, but related to COVID, but elder abuse has been on the rise in general, even without COVID. And, you know, remember that elder abuse can be defined all kinds of different ways. It's not just physical abuse. It can be psychological abuse. It can be, frankly, financial abuse, you know, people taking monies from the elderly. So it's a mix of things. And in general, older adults, and particularly those with dementia, tend to be at greater risk. So I can only imagine that in this COVID environment, things become even more heightened. But elder abuse is on the rise in general.
Mm-hmm. Okay. All right. And we have another participant is asking if you guys can provide some additional insight on how to best manage stress. And it sounds like this question is going to be both for the caregiver and the older person. So I'm just going to read it. Please provide insight into how to best manage stress. A loved one is now moving towards week 15 in quarantine in an assisted living facility. How do we best make the case to the facility to release restrictions, residents having meals in dining room, exercise groups? Your guidance would be helpful in considering about the long-term impact on the residents' physical, cognitive, emotionally, and psychological well-being in quarantine. So overall, it's like how are caregivers able to advocate for the person they're caring for with the facility.
So let me draw from a variety of observations because this one is, you know, we're right in the middle. Some could say we're right in the start. of an entirely new way of providing care in facilities as well as in the community. But I think one of the things to do, and social workers are really good at this, is to go into partnership with the other people who are working in the facility and to get them to problem solve how that kind of thing can actually be built into their everyday practice, because you do need buy-in from everyone. And if you can make the case that helping to reduce stress among the care recipients will actually reduce stress among the staff, then I think you've got a good selling point. It's really hard. The other thing that I found is, as a person whose father was being cared for in a nursing home, I would go in and make sure that I helped to take care of the caregiver staff there, so they knew that what they did made a difference. And inevitably, the quality of care that my father received tended to be much more timely and much kinder, thoughtful in lots of ways. So it really draws back to social work practice and how one uses oneself with a great deal of purpose. But I don't know, Richard and Jinyu, if you have any thoughts.
Well, I would just echo what you said, that you have to work in collaboration with the staff and sort of frame it in terms of, is it about safety and minimizing infection? How can we work around that? I know that there have been suggestions about how to create these smaller pods where people might be able to get together to socialize in nursing homes and so on, so that some of the needs can be met, for people not to feel isolated at a time when their usual contacts are being so limited, et cetera. And as Ginny was saying before, I mean, it's so important for people to, care recipients, to sort of maintain their cognitive levels and so on through these kinds of activities. So ultimately, it's going to make for better management, right, within the care setting, if everybody cooperates and problem solves and on how to improve these opportunities for the care recipients.
Mm-hmm. All right, thank you. And so, like, I'm summarizing, like a big piece is like drawing on those social work skills and values around partnership and collaborating with the facilities, and like recognizing, just as you're the caregiver, they're caregiving too. So that collaboration and partnership is key. Is what I'm hearing you guys say. And this is gonna this other question that's coming from another attendee. Still kind of goes along with this line of thinking, and the question is just like how to best engage with the facility to address the real life issues and concerns for the residents, but when the staff are not responding to calls. So in those situations, it gets to be difficult to partner and collaborate when you're not actually able to even like really reach someone, and there's limitations on being able to physically go in.
Well, I'm not sure what the exact facility is. Certainly if it's a hospital or something like that, there should be, sort of a patient advocate office and so on to sort of present your concerns without necessarily confronting healthcare staff providers about particular issues that you might be having. And I think that most licensed facilities do have some venue to address some of those issues. And I think that might be a starting part, as you, of course, as we were saying before, continue your efforts to try to maintain a, professional conversation, with the staff to really find common ground for your mutual interests, right, to provide the best level of care.
And with this too, just and Richard, you had touched on this earlier in regards to the networking and the connection that gets to take space, even in a virtual space. And so with that, any of the attendees who are on today, If you guys have had experiences with this, that please share in the group chat things that maybe that you've done, or interventions or approaches you've used that you have found helpful in any of these kind of situations. And then another question has just come in about how might caregivers balance the relaxing of state quarantine requirements and the desires of older adults to go out and do errands like groceries, hair cutting, for example. Any tips? Some of the older adults think now that there are more relaxed guidelines, they can resume normal things and not have people shop for them. So how do we manage our desire to keep older adults safe, but also at the same time respect the independence of the older adults we're helping care for?
Well, this is a very interesting question, and actually I discussed with my collaborator in community agencies. Many caregivers have such issues, have a lot of negotiations with the care receivers, especially for those, who I'm working with, the caregivers, dementia caregivers. One thing they have to do is to make agreement with facial masks. Once you go out, you need to wear the facial masks. Also, I think scheduling, people should be also very careful when to go out and where. For example, I live with my mom now. She's pretty healthy, but she's almost 70. So I suggest that do not go out during weekend. Do not go out during the busy hours. Primarily, try to avoid the kind of crowd of people and etc. I don't know what other tips Jeanette and Richard could suggest.
Well, this is a really tough one because I think all of us are going a little stir crazy, wanting to get out and get back to our normal lives, whatever that used to be, right? I think we have to try to figure out other ways to have people feel fulfilled and feel as if they're still in the world without necessarily physically being in the world. And physically outdoors. And here's the challenge. Once again, we go back to the disparity in terms of technology and connectivity. For those who have connectivity, who know how to use technology, some of my older friends, I'm in the at-risk group, folks. Some of my older friends are saying, what is helpful is to go online and look at all these, travel videos, etc., or even take a look at what's going on in different parts of the United States. But not everybody has that access. That's the challenging thing, So there are no easy answers here. And as Tiffany said, if any of you have any suggestions of ways to perhaps reduce the sense of being isolated and being, and going stir crazy, that would be really, really valuable. I think we're all struggling with that. I know I am myself. And when I go out in public, I always go out and think about all the droplets in the air, So the few times that I've escaped, I think about the shortest path to where I need to go and try to avoid the aisles where people are in and stuff. The droplets are a great disincentive for me.
Yeah, I would agree with both Jinyu and Jeanette, and I actually have this conversation on practically a daily basis with my 86-year-old mom who still drives, who still wants to go to Costco's to pick up things for the fridge, etc. And sort of just utilizing some basic motivational interviewing skills, because if I come at my mom, right, and sort of say, well, you got to think about safety and, all these practices, and it's not only infantilizing, but she's not going to listen. She's bored. She needs things. And so it really, you have to shift the conversation and start with where she is, right? And so what is it that you want to do? Is it because you're bored and you need some sort of, but what are your interests here, etc. And then, all right, so she's bored, and well, what are other things that you might be able to do that would help with boredom, but not put you at risk of infection by hanging out with people, six deep on, at a well, probably more than that, at a Costco checkout line. So yeah, trying to sort of work the conversation in that kind of sequence so that you get the maximum payoff, right? In terms of balancing self-determination with what we call, or we think it would be safety, right? For our at-risk and vulnerable elders. So that's just my thoughts about that.
We'll just take a couple more questions here before we end. We have a question coming in from Nancy, and she commented that every evidence-based services were mentioned, and I work with older blind care recipients and older blind caregivers, as well as congregate services in a senior center adapted for blind older persons and blind center staff. What is your experience with older person research that is inclusive of blind older persons and blind caregivers? I found almost no evidence-based programs that have been tested, and we have to adapt the ones so that the blind older persons could actively and independently participate.
That's an accurate observation. So yeah, we do have to adapt them. And there are a few nonprofits that serve people with visual impairment, but they're not generously funded. So you might take a look at that. Again, you might go to acl.gov and see if you can connect with one of their specialists and help them to get you to the best information that you can possibly unearth. But no, I mean, frankly, our research has been predominantly with populations that are larger, and oftentimes research is driven by funding sources. So you're absolutely right.